Good morning, everyone. I'd like to open this Board of Commissioners meeting today. It's March 8th, 2022. All commissioners are present. Their extra agenda is on the back table for those wishing. And please join me in the Pledge of Allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Now we're looking for approval of minutes of March 1st.
So move.
No, second.
All those in favor, please say aye.
Aye.
Aye. Motion passes. The next step, coordinate care organization updates. Well, Carol.
Good morning.
Good morning.
My understanding, correct me before I even start if I'm wrong, is that what you were looking for was a brief orientation to what CCOs were, kind of what the problem was they sought to fix, where we've come in the last 8-9 years with that, and where are we today as Polk County in relation to some of the contract activity that you've started to see come through in relation to our relationship with the other CCOs. So I have a quick overview. We can dive deep in any area you'd like. We can come back. So I'm just going to start and I will let you guys drive where we stop and where we just continue from there, if that's okay. Let me see if I can figure out how to get this thing to go. Uh-oh. Okay, click slideshow, so is it gonna
All you
go on
have to do
its
is
own?
click and it'll go through.
Okay. All right. So the first thing I wanted to say was that last week we had budgets due as departments. And so I might not have done all the work I normally would have on my own. So I won't say I stole this. I will say I adapted this from the CCO 2.0 introductory webinar that OHA has on its site. So I wanted to give credit to Mr. Jeremy Vandehey, who did a lot of work when CCOs came out. So I went and found a lot of their slide decks and information and have pulled a lot from there. So I wanted to make sure he got credit for that work. So what was the problem that CCOs sought to solve? Primarily, it was the cost of healthcare. And we knew that the cost of healthcare was a problem and that it was skyrocketing. That wasn't a secret anywhere. We knew that 20% of the state budget went to support Medicaid services, which here is called Oregon Health Plan largely. But it really came to a head in 2011 when the state was facing a major budget crisis. And having that significant amount of the state's budget going to a block of business that had costs that we knew were out of control was a very concerning problem. So the issues with that made it more complex at the time is that traditionally, when you sought to correct a problem with healthcare costs, you immediately started to look at cuts. Okay, well, so if you look to cut provider rates or cut eligibility or cut enrollment, you're cutting access to services for people. And when you do that, you're making the health of those people worse. So what's going to happen over time is those people are going to reemerge right back into your healthcare cost because they're going to be showing up in your emergency department, which is the highest cost point of care that you have in your continuum of services and the one that's required to serve people no matter what. So if you start going down that train of thinking, if you think about how do we solve this problem as a maze, you hit a wall right there. You can't go that way. Cuts don't work. And honestly, it's one of the reasons that healthcare costs continued to escalate over time is because we continued to use the wrong solution that continued to drive up part of the costs. Okay, so here's the other issue that we've faced. The way that healthcare was paid for was siloed. All the contracts were separate. So behavioral health had a contract from OHA, oral health had a contract, physical health had a contract. They're all separate. There wasn't anything that linked them together that said, hey, everybody work together for the good of a patient and make sure that they're healthy overall. And people were really paid for doing a service. And nobody suggested or is suggesting that the service that was given was poor. There was also nothing to assure that the service that was given was the right service or that it was quality. It was simply you did a thing and you got a check. And so what we had was a system that was really set up that was kind of widget based and really responding to the symptoms of a person that walked in with symptoms, not correcting the problem that was causing the symptoms to be present. So what you would expect and what we saw was symptoms continued. People continued to be sick because we weren't solving the core issue. Partially because a system, not a provider that was trying to do good care, but a system wasn't incentivized to solve that problem. And there was this gap in our system where they thought somebody else was solving that problem and nobody was. So we had that issue in play. The third issue that was a problem that had to be solved in order for us to correct this was that for every dollar that we spent chasing, oh no, healthcare costs are going up, let's keep pushing money into this, was money that we were taking away from somewhere else in the system because the pie of the state budget is only so big. So for every dollar we shift into healthcare, we're taking it away from housing, education, public safety, everything else. And the biggest issue with that for this purpose is that we know that if what we want is a healthy population that doesn't cost a lot of money because of their healthcare, that the key to that is actually making sure that they have access to education, housing, food security, all those social determinants that we were taking the money away from. In fact, 55% of a person's healthcare risk is based on their social determinants of health, not on their access to service, not on their genetics, and not on their behaviors when it comes to whether or not they eat well, drink or not, smoke or not. It's 55% related to whether or not they have those social determinants in place, those basic needs that we all have. And we were removing those. So everybody took a dead stop at that point and said, okay, this doesn't work. Everything we've been doing doesn't work, and looked at all the data and did some more research and laid that on the table. So what we did in 2012 was develop a new plan. And that's when the first CCO started. In fact, the state at that point, I'll move to the next slide. They started with basically this triple aim that everybody talked about. So they came up with at least here's our new goals. We have to create better health outcomes for people. We have to create more efficient care that's based on quality. So we have to know that the service that we gave actually made somebody better, not just symptom reduction, but actually fixed the core problem, actually made movement for them. And we have to do it in a way that costs less, which sounds lofty, but as we just talked about those issues, you can see how they're all interconnected. And if you find the right string to start pulling on it, all the dominoes start to fall. So we started going down this path, and the state was so confident in what they had constructed as a system to do this with that they went to the feds with a waiver and said, we'll make you a deal. If we can reduce the costs over the next 5 years in healthcare, we will save 2% of what we would have expended if you'll give us upfront money to invest into this pilot project. And they went ahead and did that. So that's what funded this first 5-year go. So in 15, we did a 5-year set of contracts where the big bulk of the state came along and started the real push for CCO 1.0 with this triple aim in play. Brought together all of the stakeholders from the 3 major areas of health, so oral health, primary care, or physical health and behavioral health, changed how we did contracting, put them all together into these global budgets, and tried to produce this outcome. At the end of those 5 years, in fact, we were able to do that. They were able to get that savings into the system at an estimated savings to the system of $2.2 billion over those 5 years. We found that one of the pieces that was part of the 1.0 rollout was a number of quality incentive measures. So there were a number of quality points that were done in the system that the state put out, and all the CCOs had to track whether or not you were following these different target measures, and if you as a group of providers could achieve change overall with those different quality measures. So we were seeing that there were quality changes happening. And the costs were getting lower and people were getting better. We saw more people being signed up with primary care than had ever happened. We saw more people getting measurable changes in their risk stratification. So when a member gets enrolled in services, based on a number of factors, they're kind of given kind of a score for what do we think your health risks are. We saw people's scores coming down. They were less likely to pose a cost to the service based on their health. So things were going in the right direction. So then we came upon 2020 and we were ready to launch CCO 2.0, the second round of contracts. So the state went through a massive research project at that point to say, what have we learned and what do we want to now improve on? Locally, and I'm not going to go into this as part of this, but just as an aside, we had been a part of one CCO as a county at that point, which was Willamette Valley Community Health. And we had a number of partners and we'd created a system for our CCO. At the end of those 5 years, we had learned a lot and we thought we could do it differently. So led by Commissioner Pope and his band of folks, we went and met with partners who had also been doing this in a different way with Pacific Source and explored the ability to recreate what we wanted locally in the Willamette Valley with them. So when we recreated this under 2.0 with the new contract cycle with the state, we applied as a different organization with Pacific Source, which is what we now have in place. So you're going to see if you look back that in the past, there was a first CCO with Willamette Valley Community Health, and the second contract phase was now under,
Specific.
what's that?
Go ahead.
Yeah. So now we're with Pacific Source. So with 2.0, the governor had a set of recommendations. She amended a lot of what we saw in OAR related to CCOs. They had a lot of new requirements because we wanted to push it out even further and continue to drive the costs downward. So some of those changes were the CCOs had to go further with developing different funding formulas. So rather than things being what's called fee for service, so instead of you do something, I give you a check, it was, no, I'm going to give you a set of funds and you continue to show me how you've affected total health costs by doing these things. They're called value-based payments and there's lots of ways to do them, but basically no more widgets. Show me quality outcomes. Show me how total health is being affected at a community level. Show me how you're flipping the conversation from paying for healthcare to being able to reinvest money because you've created savings into the social determinants, because that's where 55% of the impact lives. We have it on the wrong side. We're trying to move it over. So in 2.0, that's where the conversation has moved to. We still have these targets for quality purposes where the state still has a list that each of the CCOs pick from and say, these are the things we want to work on. And there's bonuses basically built in that if we can achieve those bonuses, that there's more money you can get by going and achieving those. There's a lot of focus, as you guys well know, on crisis services, on social determinants. And so it's really a different conversation than where we started in 2012 talking about healthcare and things that were really thought of as something happening in a primary care office. That's not the conversation anymore at all. The conversation is much more about all of the partners sitting around saying, okay, we all know what we all do individually, but we're here to come together and talk about how we're going to change systems at this point. All right, so really what are the nuts and bolts of a CCO? What's inside it? How do they work? Well, first of all, they're community governed. So when you apply for it, you say, what's the scope of the community that you want to represent? For us, it was largely the Marion and Polk area. It's physical, behavioral, and oral health coming together. So all the funding that the state would normally give, they put that all together and pool it and hand that to the CCO and call it what's called the global budget. So they're giving them all the money up front for the Medicaid portion of the services needed for those services. And they give them the flexibility to then spend that how they need to in order to achieve the outcomes they're responsible for. So not only are you responsible for kind of the professional service that they're providing, but you're also responsible for all of these other outcomes that have been applied in statute now. So, and those are the things where we talked about those value-based payments and these outcomes. So one of the prime examples of that. The reason for the flexibility, so I'm going to give you this, most of us have heard 1,000 times, but in case you haven't, is there's a number of things that we know impact health significantly that don't sit on a nice little code, that aren't reimbursed for a diagnosis on a code guide from CMS. So the example that's gone around for 1,000 years, and I'm probably giving you version number 900, is you have this person who's been in the ED, 9 times over the summer for some horrifying condition, because every time the temperature goes up, their condition is getting set off, and now they're going to the emergency room to get treatment, all because their apartment is getting too hot. Well, we continue to do, they're in the ED for who knows how long, or getting admitted for who knows how long to get them stabilized again, costing us X told thousands of dollars to send them back home and repeat this cycle. When the solution is not all these meds, not all this time spent by the docs, not all the time spent in the hospital, but simply buying an air conditioner so that this never happens. Problem is, there is no diagnosis that allows me to go take Medicaid dollars and purchase an air conditioner, because that's not an intervention that the medical codes recognize. That's not a medical service. So the global budget the CCOs have give them the flexibility to spend it in a way that brings common sense into the game, brings those social determinants into the game, and allow you to do the things that make sense to affect healthcare the way you need to, as long as you're able to meet all the requirements. And then the extra piece of what makes the CCOs fun is that as they are managing these global budgets and hopefully achieving savings, because by doing these things that make sense, you're driving down the cost of healthcare, you get to take the savings that you've achieved within this budget, and then you get to reinvest it into that community with new initiatives, new investments, and find other ways to continue the cycle of flipping the cost from the healthcare at the end because somebody has now gotten sick to the prevention side of making sure you have enough resources in place, enough of the social determinants in place to prevent people from getting to this place in the first place. So for us, talking a little bit in specificity around the Marion Polk Cco. Well, first I'll back up just in general. On a state level, there are 15 different CCOs in play under 2.0. Most of them are for a single county. And then I know this is pretty small. I can get you this later, and I think you have it on your computers. You could probably get it a little bit bigger if you wanted to. There are a few CCOs that are in multiple counties, and then there's a few counties that have multiple CCOs covering their constituents. By and large, we have functioned up until very recently as if we only needed to worry about the fact that we were covered by Marion Polk Cco. It's not entirely true, but I'm going to talk about that in just a minute. So largely, we've operated with our primary partner, which is the Marion Polk Cco, which has Pacific Source Community Solutions as the parent company that operates it. And the structure is a little bit confusing. So you've got Pacific Source, which is a huge insurance company with all kinds of books of business, both commercial as well as Medicaid. Community Solutions is the one that operates their CCOs, and they operate 4 different CCOs in the state. So they've got Central Oregon, up in the Gorge, Lane County, and then Marion Polk. Then I mentioned that CCOs are governed locally. That's one of the things that's key about them. So for us, we have developed the Willamette Health Council as the local nonprofit that governs our CCO. And it's made up of a number of different local providers. So we have we've got primary care, dental providers, specialty care, the counties are on the board, community members are on the board, consumers of Medicaid services are on the board. And we operate as the governing body over the CCO that manages the finances for the membership. So it's a hybrid relationship that works in partnership with a check and balance system, hopefully to make sure that what's intended to go to the community is actually serving the community the way that we intended. So way down there in dark blue, that's very hard to read on this, And what's even harder to see is if you find Polk County up on the map, you'll see most of it's in green, and that's Pacific Source. But up at the very top, you'll see a strip of brown. And that strip of brown actually belongs to what we affectionately refer to as YCCO, but that's actually Yamhill Community Care. So when the state assigned CCOs, they did not do it necessarily according to any county lines. They did it, I'm not really sure how they did it, to be honest. I've heard different theories. But they assigned about 2,500 residents of Polk County to Yamhill Community Care. And I think the reason they did it was because of where they lived. They just kind of thought that was the natural flow of where those people would find it easiest to go.
I think they're also served by YCOM, which is the communication center for Yamhill County. They have about 11% of our population.
Oh, okay. So maybe that was another, maybe there's other relationships that make
That's
that
why
natural.
it's only in the north and it's kind of a jagged line. And that may be something else they follow. I don't
Yeah.
know. But there's another theory.
So we've got this pocket up there. So I know that you heard in the last couple of weeks that there was a contract that was going to come soon to have you entertain, that was going to be between us and Yamhill Community Care for local mental health authority services pertaining to those members. And I wanted to explain a little bit about why that would be happening and what it was and what it was not. So this goes back to kind of this evolution of between CCO 1.0 and 2.0. In 1.0, there were rules that were not in place or requirements that were not quite in place yet for CCOs and wasn't as tight. In 2.0, they really tightened up access and what had to be in place to make sure that all of those members had the ability to access services they needed in a variety of ways. And they put the onus of that really on all the CCOs. Prior to that, we have always had the obligation as Polk County and as the local mental health authority to make sure that every resident of Polk County, regardless of anything else, has access to safety net services. And those safety net services are going to be crisis. They're going to be any other behavioral health service that we are providing and offering if that individual doesn't have another way to access it. And so we're already doing this. We have been doing this well before the inception of CCOs, and throughout CCO 1.0, we did it. Really what changed, and the reason that it's coming up now, is when 2.0 came on, Yamhill Community Care was given a 1-year contract instead of a 5-year contract like everybody else. And part of the reason for the 1-year contract is they did not have all of the requirements in place. Requirements they did not have in place is they had not met all of their access obligations. And part of that was having a contract with us that said, hey, you need to make sure that that Polk County is ready to serve them. Polk County knows they have to serve them, but the state has given given the money for the services for that to Yamhill. And the state wants to make sure that there's a way that that flows through to support that. And then there's some other things that we need to be prepared to do, and we have been doing. In fact, we have been at times billing them for things that we knew we were supposed to do, even though they weren't necessarily asking us to do it formally yet, because they didn't have all of their infrastructure in place for quite some time. They've just, in the last probably 18 months, it's during the pandemic, finally gotten their behavioral health director in place for their CCO. And that's really what caused all this energy to start to come into play. They got a very qualified, very competent person to be their behavioral health director. I worked with her years ago when she was the behavioral health director for Deschutes County. So she knows her stuff. She's come in and identifying these holes and has looked back in history and said, hey, we've actually kind of been doing a lot of this naturally, but we didn't have any agreements. There was nothing to say what we were actually agreeing to pay each other when these things came up. There wasn't anything that actually formalized that we would be paid for doing things, because we as a county were obligated to provide them regardless. Yamhill had been doing a nice job in most instances of going ahead and honoring that, but we needed to put something in place that made that official. And then under 2.0, they have obligations to have agreements in place that make sure that for other issues, such as if we have one of these folks in Polk County that's not able to get their services under YCCO very easily because of distance or wait lists or things that YCCO hasn't been able to fulfill, those residents would be able to get those services from us. And then we need to make sure we have a payment mechanism in place that we're going to be able to recoup that cost in a way that's equitable for us. So what that agreement would not be is an open provider agreement. We are not seeking a contract to provide services to YCCO members. We're wanting to make sure that we're paid for services we provide to Polk County residents, whether or not they have YCCO insurance or not, under those circumstances when we are required to provide them that service. So we go through a bit of a due diligence process on our end to see if they screen in or screen out of that. But there are some things that we're required to do and that they're required to work with us to provide them that had not been happening. And if we're going to begin to do those moving forward, we would like to take advantage of the fact that there's some work on our end that would be nice to see some compensation for. For example, that's a whole separate CHA-CHIP process that we'd be working on them with. There's a behavioral health plan that's required that they do. There's a system of care and some different meeting and administrative requirements that they have that they're recognizing. And because that we have residents that they're working with, that's going to involve us. And so they're offering to recognize that and to make sure that there's some administrative compensation included into that contract for those things that we're going to need to do with them. So that's the gist of why you're seeing that contract come in. In the future, there may be a different conversation about opening that up to a larger type of provider contract. At this point, my response to them on that has been, as a director for behavioral health, I couldn't in good conscience move to something like that when we have workforce issues the way we do. Because my first job is to make sure that we've taken care of Polk County before I start looking towards anybody else. And even if we did, I don't think at this point, I have not heard from you all that we have any interest in growing our book of business. At this point, that hasn't been something that we've seen as advantageous to us. If that were to change, it's something I'd be happy to look into, but that would be something that I would want to see directed from this board and not for any other reason. So I think that concludes my general overview. What questions do you have?
Oh, gosh, I have a myriad of them. So,
Uh,
no, thanks, Noel.
Yeah.
You did an awesome job. It's very complex, clearly, and it's we've been a decade getting here, and it's been fascinating, at least for Marion and Polk County, to watch the, not only the challenges of the triple aim and getting everybody in that mindset, which took, well, I think we're still working on it. But it was a solid 6 years just to get to a place where we could just have a conversation about that. Our first 2 years in this process was just fraught with challenges of who's going to survive financially as a provider, and counties included. And then arguing over statutes and safety net issues, which was probably our biggest fight, was constantly having to remind people statutorily the county has a mandate to provide this safety net service elements. It's in the law. We have to do it. It doesn't talk about we have to get paid. It just says we have to provide it. And of course, our job is to see to it that we keep a balanced budget and that it gets paid for. And so even though there's a massive amount of money flowing through this, there is still inherent danger all the time for Polk County, Marion County too. But for Polk County, it's different because we don't have partners in the behavioral health world. And so to answer the question from the ending of your statement about book of business, no, I'm not interested in the least in increasing our book of business. It will come organically. It will be forced on us whether we like it or not, because again, as I said, we're the we're the resource for behavioral health in Polk County, generally speaking. Do we have any at all? Do we have any providers in Polk County that we point to?
No, not,
So I didn't want to overgeneralize this, but I wanted to make certain to point to that. I worked, thank you, Noel, for recognizing that you and I both worked really hard to try and change the direction of the CCO for CCO 2.0. There wouldn't have been a 2.0 for us, really, if we hadn't done what we've done with some other key partners in the region to go look at another alternative from where we were. It was apparent where we were was going to end up overrun both politically and financially by some very large providers in the region. They were going to get control of it. They had every intention of just taking over and making certain that they protected their interests. So we could see that was likely. And so even in the face of, we got told, you know, this plan with Pacific Source couldn't survive. It wouldn't work. And it wouldn't have if Pacific Source hadn't been willing to say, okay, well, we'll explore it with you. It wasn't really at the time their intent to do this. And so we had to work pretty hard to get them to come along with us and really look at it in the face of all the challenges from other folks in the community. So I'm interested in knowing whether or not you see any kind of metrics that show our participation rate in 2.0 alone. So we should have had a pretty good idea, you know, what our total per member, what our members were coming into this, our transition from WVCH to Pacific Source. Do we have a way of seeing that right now? Are we gaining members? Are we losing members? And because again, there was always a fear of, you know, some folks will slip back into fee for service.
so you're asking for total membership?
Yeah. Do you have a sense of, are we gaining ground in the membership?
I think it's been complicated by the emergency declaration and the fact that we haven't seen people fall off membership.
Gotcha.
So yes, so total membership is well above what we anticipated, but I think that that's been inflated because we haven't had the redetermination happening.
Can you, and so I also note for the record that Noel sits in the board seat that I once had in establishing, you know, Willamette Health Council. And when we got it up and running and it was apparent that this was going to be more now a conversation about clinical needs and organizational needs for community members and such, you know, Noel and I agreed, Noel's better suited to sit in that seat than I am. So that's why she's in that spot. And I'm hoping that she still thinks that was a good decision because I don't want it back. It's very complex work. Again, I spent easily half of my portfolio, easily half of my time just doing this work. So I'm very passionate about making sure it's successful and keeping it going. Can you tell us what the gross dollar volume per year is right now for our CCO?
I can't. I'm happy to give that back to you. But I actually, to be honest, with the things that were happening last week when I found out that this was something you wanted, didn't get too much into the detail. And that was partially at my understanding of what Mr. Hansen wanted me to bring today. But I can go get you any of that you.
No worries. I just thought maybe you might have it off the top
of my head. No.
As you may recall, Willamette Valley Community Health was in the $500 million a year range.
Yes.
Of Medicaid dollars. And so that's been a number of years ago. And so I'm confident that number has grown significantly because Medicaid has grown significantly across the nation. So that's at least the minimum basis, but I'd like to know that when you get time,
Absolutely.
You know, just kind of get a spotlight on how many dollars are we actually investing of that federal bucket into our region. And then you probably wouldn't know this either, but I'd like to know also what's Pacific Source's percentage. So I know that it was a small percentage of the balance that they get out of this, but do you have a sense of where that is and how much of that, also how much of our share goes to the Health Council? Again, just for the basis of everybody understanding, how much money does the CCO get to control? How much does Pacific Source control?
I believe only 2% goes back to the CC, or goes back to Pacific scores, but I'll get all that back to you in hard numbers. I don't want to
Okay.
speculate too much for the record.
Thanks. I would ask, and again, maybe you might not have the answer to this today, but how do we measure success? I mean, how do we know that it's working today?
Yeah, well, I think that the way that we're seeing it measured, I mean, one of the ways that it's very easy is really the global budget, because we're given a set amount based on anticipated healthcare costs. Everything from there is carve out your savings. If you can do better, and then do what you want with it. So we're really incentivized, both in terms of providers get to make some determinations about what will benefit them. And that's not always, in fact, rarely is that a conversation about we want more money in terms of rates. That hasn't always been the case, but that has not been the case with the Willamette Health Council conversations. It's really been, how can we reinvest this into the community? So as we're seeing those savings, that's an easy way for us to see kind of your scorecard. The second way that I think that we're able to see that is in through the quality incentive metrics. I mean, we have very clear metrics that we are signing up for each year and saying, these are the ones we want to take on. And quarter by quarter, we're able to monitor our progress on those. So there's a very clear data sets that we're able to see how we're doing. And I'm happy to send those along if that's something you guys would like to see, as to where those are at.
I just think it's important for us to, again, here we are sitting in front of you talking about something I think really for the first time in a long, long time. And I want to make certain that all the commissioners are aware of what this is and how big it is, and it's not just business as usual. It's a very big deal. And I think finally, I think it's important to note some of this just for the record, so that anybody listening can understand what the impacts could be to Polk County in general, but behavioral health more specifically. If there's a run on service need, or worse, there's a provider or a CCO, in this case, YCCO, that either is pulled out of the system politically, which was a danger. That's one of the reasons that they only got 1-year contract, right? Because they couldn't provide all the information that the state wanted them to have. But what that impact could look like for Polk County, because we don't get to turn anyone away. We're required to serve them. And so I assume that all the rules were in place when I was on the board are still in place. You can't turn anyone away. You can't refuse service. And you absolutely can't say, well, look, we have just this much capacity. We're going to take care of Polk County citizens first. That's not an option.
Correct.
So
the difference, it's not really a difference, but I think how I've seen it being addressed is that you do have the ability for the CCO to independently contract with other providers. And so we've seen a lot of that in Marion County, where the county does not provide the bulk of the service delivery. It's really contracted out to other either onesie-twosie independent contractors or a small practice, or you'll see this myriad of practitioners that they've gone and contracted independently with and kind of formed a network. And I wanted to correct something for the sake of the record versus kind of how I was originally thinking about it. When you pose the questions to other providers within Polk County, there are a couple of actually other behavioral health providers within Polk County. They just tend to be within West Salem, and I tend to think about them as part of the other network. But Northwest Human Services does have a significant bulk of business for behavioral health, even in West Salem, and options counseling is in West Salem as well. So I just wanted to correct that. But outside of the West Salem area, we're really it. So yeah, there could be a way for the CCO, because that's where the onus also lives. The difficulty with the way that statute has things framed up right now, and I think everybody is aware, OHA is aware, governor's office is aware, they haven't found a way yet to blend these in a way that's it doesn't always make sense yet. You'll find that we have statute that still conflicts. It isn't clear about where the ownership lies. And so you end up with things like, I think a great example is the Health Advisory Board. And I don't know that we have a time for that conversation today, but we're responsible for making sure that there is a local plan that meets the needs for behavioral health for our community. And yet the OARs will tell you that that's why we created the CCOs, which has a requirement for a community committee, that's their very purpose in statute, is to make sure that the areas it represents, being Marion and Polk County, has those local representation needed or met and reflected. And so which one of us is supposed to do that, or is that simply just a duplication of effort? And so getting those resolved is something that I think everybody knows has to be done. And there's a lot of discussion around that being taken on in the next contract year. But they're all over the place and really trying to resolve those relationships. Where does the LMHA's obligations end? Where does the CCOs begin? Where are they supposed to work together in concert? Where does one have authority? How will that work? And who contracts for what, and who at the end of the day has the responsibility for making sure that the people's needs are met? Right now, sit with the answer being both. You're both fully responsible for making sure that services are delivered. So yes, we are at risk. I think we had a great partner if we were in a spot that would help us to find a solution for it. The danger to the flip side of that is we might not like the solution that they came up with, which could have other impacts to us that could also pose different dangers. You know, we have a lot of our budget built on a certain level of service delivery, which brings in a certain level of revenue that we are able to use for our own budgeting purposes. So yeah, it is definitely a risk factor. And if we were to be overrun with a new population, that would be a difficulty.
So for the record, though, in West Salem, we have our satellites. We're also one of the main players for behavioral health
Yes,
in that community as well.
yes, we are.
I just want people to know, and that's located right behind the Safeway store.
It is, yes. And we are one of the main clinics over there as well.
Yes.
I
and
just
that's-
didn't want to incorrectly say that we were the only one over there. But
yeah, and that is the walk-in at any time to get help,
Mhm.
along with appointments. So
yes,
I just want people to know that that's there.
yes, we have the walk-in crisis clinics over there at any point. We have same-day access over there. So people can come and get seen for an assessment any day.
And another one on Monmouth and Yes Curves,
Yep,
the satellite, same process.
same process.
And I just wanted to commend you two for your efforts you put into this, because when I first got appointed, I wasn't sure exactly what all this was, but all I knew is Commissioner Pope, you were the main target in the whole valley. How you were personally pushing this on everybody. Everybody else on that.
The change, not the system.
The change.
The change.
The change. But you saw need and you went for it, and you two did amazing. So I know that was a huge process. And I think now that everybody's looking back, there's still that small handful that lost control. They're still very frustrated, but everybody else is finding out that this is working extremely well. And this saved us a ton of money. And we have a much more efficient program, it looks like to me. Looking from what I've learned since then, walking and knowing about background things, to understanding what being the, what's the title for we are the health providers or
Local mental health authority.
local mental health authority. That's something you think by now I'd have down and measured and just locked in
There's
my
local
brain.
public health and local mental health.
But I just want to commend you on that. How many employees do you have now? In mental health, underneath your guidance, not counting FCO, but
Right, we've got about 150 employees, but there's contractors and students and everybody we've got in there. The workforce is around, it's a little over 200 people that we have actually doing.
and I just want people to know the size of this. This is amazing. And what you provide and how far you reach is very impressive. And thank you for all your efforts, and share that with your crew.
Sure, thank you. And yes, I'll try to get back to you with some little more in the weeds numbers so that you can understand just the scope, because it really is a significant portion of money that's going into this. So.
Is there a, and I know I've asked you this before, I just don't remember the response. Is there a quarterly report the Pacific Source puts out, or that the Health Council puts out that can be shared with the commissioners in both the counties?
I haven't seen something like that. I mean, there's the monthly report to the board, that's coming out of finance, and we're taking a look at quality metrics quarterly. So we could probably put something together that would be shared, and that would be easy just to kind of let you follow the trends about how we're doing kind of from that high level. I don't think that would be a big lift.
I think it might be helpful, again, given the size and scope of this and the responsibility of county government and the commissioners.
Yeah.
To seeing this through, that, a reporting, even if it's twice a year, I'd be fine with that.
Okay.
That says, here's where we are, gives us a sense of the ebb and flow of membership and the dollars. And so that, one day something's going to change in the federal government in disbursement. And then we're all going to be standing here with shocked looks on our faces and not really understand why or what happened. How'd we get here?
Yeah.
It can happen. It's happened before.
Yeah. Right now, most of the communication is, I think, broken down for the audience. So, you've got a presentation to the board that's got a certain flavor on it, and then there's a presentation to finance with a different flavor, rather than something being really brought up to a high level. So I'll talk to Justin and see if we can put something like that together.
I will tell you also, there's likely to be some of the same kinds of concerns, although Noel and I worked really hard to make certain that this 2.0 version was as transparent as we could get it to be, given the fact that we have an insurance company who manages all of this and isn't required to meet public meeting law. We worked really hard to make certain that the Willamette Health Council was open to public scrutiny. And I think there was some language in the legislation also that said you need to do that. But the 1.0 iteration, we were all sworn to secrecy. We weren't allowed to discuss the business of the CCO here in the room. I wasn't allowed to, and I could be sanctioned if I had done that, which was a really unfortunate thing. So doing my best to make certain that to cover the county's interests through that process, yet not able to talk about it publicly. And I mean, Greg and Noel and I were all parts of those conversations going forward and trying to strategize how to make it work. And you can see what the result was. That we said, this isn't going to work for us. This isn't good enough. We had an opportunity to do something different. So I'm grateful. Please share that again with the board members, as I have in the past, for their hard work and their transparency and their outward looking opportunities. So best of luck to you all.
No, this is a well-functioning board. I'm happy to be a part of this.
Oh, the BCN wasn't?
Oh, I missed the BC.
Well, that wasn't fair.
That's different. That's
Nothing,
different.
had nothing to do with the leadership.
No,
I'm certain of that.
No.
And I love the fact that when we talk about numbers and budgets, Mr. Hansen's name always comes up no matter what
Yeah,
avenue we go down.
he's the voice of reason for most of us.
Thank you,
That's
Nicole.
scary.
Really helpful.
Thank you, Noel.
Or no, I'm sorry.
Any non-listed items today? None of that. We're adjourned. Thank you.